Hello, everyone. I'm Dr. Samuel Washington. I'm a urologic oncologist and assistant professor in departments of urology as well as epidemiology and biostatistics. Here I'll talk about our project presented at ASCO, which was titled Biomechanical Computed Tomography Improves the Diagnosis of Osteoporosis and Fracture Prediction in Patients with High Risk or Metastatic Prostate Cancer. The goal of this study was to look at how well we diagnose those men who may be at risk of osteoporosis as they're getting long-term hormone blockers for prostate cancer. We found that the standard bone density screening methods using a DEXA scan may be missing some men who may be at risk, and also many of the men don't get DEXA scans to assess bone density health or bone health before treatment. We decided to examine the opportunistic use of BCT, Biomechanical Computed Tomography, which is a CT-based way for us to look at bone health rather than a separate scan that's harder to get. Overall, we found that using this BCT analysis improved our ability to find people who have osteoporosis or at high risk of bone fractures due to weakened bone strength. And it helped with our fracture prediction using routine CT scans that everyone gets rather than DEXA scans, which are hard to get and a lot of men don't. We observed significant fracture risk not only in men with fragile bone strength and known osteoporosis, but also those with low femur bone strength and lower density. These men may not have otherwise qualified for medications to promote or strengthen bone health. So here we're able to identify people who may benefit from treatment who may not have gotten it otherwise because they were missed with standard bone health screening tools. So we're excited about the use of BCT and how this may close a gap and address a need that we may not have even known was present. The key or the issue with implementation for a lot of new strategies, new analyses, is the upfront cost, meaning you need a new scan, you need some other software, you need something else. Here we're able to leverage scans that men already are getting as part of their workup for potentially metastatic prostate cancer. So those men who are already getting CTs as part of their prostate cancer workup, we can now analyze them in a different way. So we actually lower the bar for access because men don't need another scan. All they would need is essentially analysis of the CT images, which we have now. So the bar for introduction into clinical practice, much lower, because it's really a software issue rather than a new scan, new clinic appointments, anything else that would be required otherwise.